Dear students, my name is Yasmin Rüstəmova and I'm delighted to welcome you on our lecture which will be dedicated to cardiomyopathies. Of course, just in 1 hour, talk all about the cardiomyopathies, it's very difficult, but I will try to be brief and give you some introduction into cardiomyopathy. So let's start with the definitions. First of all, I want to tell you that all the knowledges that we know, and especially here talking about the cardiomyopathies, I'm going to link to European Society of Cardiology. And this definition was actually proposed by the Working Group of Myocardial and Pericardial Diseases of European Society of Cardiology. So the myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease sufficient to cause the observed myocardial abnormalities. So, the cardiomyopathies are the diverse group of disease that are not related to usual causes of heart disease such as hypertension, valvular congenital disease, or pericardial disease. Cardiomyopathies are classified according to anatomic or hemodynamic characteristics and etiology. So, why cardiomyopathies are important? So first of all, they can lead to sudden cardiac death, and also sudden cardiac death can be the first symptom, first sign, not symptom, but first sign of the disease. Cardiomyopathy also can lead to heart failure, and then the heart failure will lead to death. Also, cardiomyopathies as a complication of it can lead to atrial fibrillation, and atrial fibrillation can lead to thromboembolism and lead to stroke. So why it is very important. So I want to emphasize again. So the cardiomyopathies can be primarily, we are going to talk about it in more detail, and could be also secondary cardiomyopathies, which will be due to some diseases. But also exists the functional classification of cardiomyopathies. So first group, this is the dilated cardiomyopathies with a ventricular enlargement and systolic dysfunction. Second group is the hypertrophic cardiomyopathies, when an inappropriate myocardial hypertrophy exists in the absence of the other disorders which can lead to the hypertrophy, for example, hypertension or maybe somehow valvular disease like aortic stenosis. And the third group is the restrictive cardiomyopathy, in the case when in the myocardium there is an inclusions or infiltration of the myocardial masses with the proteins or glycogen. We are going to talk about it also. So in restrictive cardiomyopathies, the basic of the pathophysiology is the abnormal filling and diastolic dysfunction. So let's talk about the morphologic and hemodynamic characteristic of these three types of cardiomyopathies. In dilated cardiomyopathy, we can have either isolated left ventricle dilatation, or the dilatation could be biventricular. And in this cardiomyopathy, we will have a decreased cardiac output. What is cardiac output? And also stroke volume. So these are two meanings. They are all related to, associated with each other. Stroke volume, this is an amount of blood which will be the amount of blood which goes from the left ventricle to the aorta in the one heartbeat. And the cardiac output is the stroke volume per minute per beat. It means this is the amount of the blood which goes through the aorta within the 1 minute. It means that when we have a decreased stroke volume, Of course, we will have also decreased cardiac output, and then we have an elevated ventricular filling. And also, as we said, there is an enlargement of ventricles. We will have a large also chamber size, not only of ventricle, but also of atria. Because when we will have the dilated left ventricle, we can also have the dilation of mitral valve, for example, and then the valve will be not closed so tightly that will lead to mitral regurgitation, and this mitral regurgitation will be the cause of the left atrial dilatation. Of course, in dilated cardiomyopathy, the pump function, so the systoling function of left ventricle, will be also depressed, and sometimes it is depressed very, very severely. In hypertrophic cardiomyopathy, the pathophysiology is a little bit different. There is a marked hypertrophy of left ventricle. Occasionally, it could be also of right ventricle, but when we talk about the hypertrophic cardiomyopathy, it mostly related to left ventricle. And it is always this, and usually, but not always, we can have a septal hypertrophy more than other walls of the left ventricle, and that will lead to the asymmetric or obstructive hypertrophic cardiomyopathy. In this type, we will have a normal cardiac output, of course, with a normal or maybe also elevated stroke volume, but the chamber size, when we talk about the left ventricle, will be normal or even small because of the severe hypertrophy. We will have the normal or maybe elevated ejection fraction because when there is a hypertrophy, the end systolic volume will be smaller, and of course the diastolic compliance will be also impaired. When we talk about the restrictive cardiomyopathy, this is the reduced ventricular with reduced ventricular compliance, usually caused by infiltration of myocardium by amyloid, hemosiderin, or glycogen deposits. So the cardiac output also in this will be either normal or depressed, as also the stroke volume, because we talked already that the stroke volume and cardiac outputs are related to each other. The chamber size, if we talk about the left ventricle chamber size, will be normal or could be also dilated, but it depends on the type of of the disease. But we will talk about it more detailed. So let's talk again. The cardiomyopathies could be primary with unknown cause. And mostly when they don't know the cause, they are genetically. So also it is, as we said, it's dilated, hypertrophic, or restrictive. But also the cardiomyopathies, they can be related to some diseases. For example, when we have an inflammation in the heart because of the myocarditis, that could lead to dilation of the left ventricle, and that will be also dilated cardiomyopathy, but because of the inflammation, because of myocarditis, for example. Dilated cardiomyopathy could be also as a systemic, one of the cardiac involvement of the systemic disease, or it could be toxic or ischemic. So secondary cardiomyopathies, it is when the cardiomyopathy has a definite etiology. Let's talk about the idiopathic dilated cardiomyopathy, because in the other cases, all causes that lead to cardiomyopathy, we have to treat, of course, the etiology. But now we are going to talk about the dilated cardiomyopathy itself. It means that without primary dilated cardiomyopathy. And this is how it looks like actually in the autopsy. This is the short axis view. And you can see here the very severe isolated dilatation of the left ventricle without any involvement of the right ventricle. And as you can see here, there is in centimeters. This is about 9 centimeters. So this is the huge dilated left ventricle. How can we see this dilated left ventricle? To be honest, it's very easy because now we have the ultrasound examination, which is echocardiography, and in transthoracal echocardiography, this diagnosis could be done easily. So this is here when you can see the image of the echocardiography. This is the parasternal long axis view. You can see here the left ventricle, which is dilated. You can see here this is the left ventricle, this is the right ventricle, this is the left atrium, and this is aorta. And you can have here the dimensions, and you can easily make the diagnosis whether there is dilatation or not. Here, for example, this is absolutely looks like normal. Let me see. Yes, this is about 45 millimeters of the left ventricle, which means it is normal. In here, I gave you the normal ranges, normal parameters of the 2D echo of left ventricle size and function according to gender. So normal dimension of left ventricle is maximum until the 56 millimeters. This is the end diastolic size, and the end systolic size is maximum is about 40 millimeters. We are also able in 2D echo measure the volume. So not only the sizes, not only dimensions, but also the volumes. And here you can see the apical long axis view, and you can easily measure the left ventricle and diastolic left ventricle volume, and also end systolic volume. As you can see, when we have the idiopathic dilated cardiomyopathy, when it mostly genetic type, we will have the absolutely different shape of the left ventricle. And as you can see here down, the left ventricle is very, very dilated. It's big, but also the shape from the upper left ventricle is different. It's more rounded. So this is which is typical to the idiopathic, to the genetic one of dilated cardiomyopathy. As I told you before, in dilated cardiomyopathy as a complication, we can have the dilation of the mitral annulus, and that will lead that mitral valve will not close properly, not good enough. And that's why we can also have this regurgitant flow just back from the left ventricle in the systole, back from the left ventricle to the left atria. And that will, of course, overload the left atria. And within the time, the left atria will be enlarged as well. As we talked previously, so when is idiopathic dilated cardiomyopathy, but dilated cardiomyopathy can be also secondary. For example, due to the pregnancy, and then we will talk about the peripartum cardiomyopathy. It could be due to the toxic, for example, due to alcohol or somehow drug intoxication. Dilated cardiomyopathy could be tachycardia-induced cardiomyopathy, and this is very difficult to diagnose because when you have a patient with dilated cardiomyopathy, he will be probably in tachycardia. Why? Because this is some of compensatory mechanisms that are switched to compensate this very low stroke volume and cardiac output. So to make a diagnosis of tachycardia-induced cardiomyopathy is actually very difficult. It could be, as I told you previously, infectious, like myocarditis. And of course, it's very important to have the good and the history. You will have to ask patient very, very detailed the history. So the dilated cardiomyopathy could be also ischemic origin. But of course, as I told you, when you have an ischemic origin of dilated cardiomyopathy, we will have the left ventricle will be dilated, but it will be the regional wall motion abnormalities, which will be due to the stenosis, to the obstruction of the one of three main coronary arteries. Whether in the idiopathic dilated cardiomyopathy, we will have the globally reduction of the contractility, not segmentary. We talk about the infectious, about viral myocarditis, etc. We talked about the toxic, and also I want to emphasize that is very, very now is very modern a topic to talk about the cardio-oncology, because the oncology patients, they receive the anti-cancer drugs, which are very cardiac toxic, like doxorubicin, for example. Systematic disease, we talked about it. Somehow in children, when you have a dilated cardiomyopathy, it's not always the genetic one. Sometimes it could be because of the, for example, selenium deficiency or maybe carnitine deficiency. And this is also very important to diagnose. And about known etiology of ischemic, we already talked. Why it is potentially reversible? Because sometimes the dysfunctional myocardium is not always because of the fibrotic tissue, which has replaced the myocardium, the muscle itself, because of previous myocardial infarction. But sometimes because of chronic coronary artery disease, we will have the hibernated myocardium. It means that the dysfunctional myocardium is not replaced by fibrotic tissue, but in the basis of this dysfunctional myocardium is viable myocardium, but with very slow metabolism, which leads to the wall motion abnormalities, which you can see just only into the echo, and you will say that there is a hypokinesia. It means that the function is actually impaired of left ventricle, but this impairment is not because of the replacement of muscles by the fibrotic tissue, but because of the hibernating myocardium, because of the very slow metabolism. We talked about it already. Let's switch to the characteristics. So let's switch to the pathophysiology. What will happen in the organism, in the human body, when we have the dilated cardiomyopathy? So first of all, when there is a severe dilatation of the left ventricle, of the left ventricle, then the left ventricle ejection fraction, which is normal is more than 55%, will be also depressed. And this severely depressed left ventricular function will cause the low blood pressure. And as the human body, as the organism will try to compensate it, it will lead to the increased systemic nervous, it will lead to sympathetic nervous system activation. Why? To bring the tachycardia. So as we have the low blood pressure, the activation of the stimulation of the sympathetic nervous system will lead to the tachycardia, to compensate the low blood pressure. And this also will lead to the activation to the renin-angiotensin-aldosterone system. And this renin-angiotensin-aldosterone system will, how it works. So the angiotensin again is in the liver, but to make it active in the kidney, renin release from kidney will activate the angiotensin again, which comes from the liver. And the renin acts on angiotensin again to activate the angiotensin again to make it angiotensin 1. And then the ACE, which is angiotensin converting converting enzyme, which is released from the lung, will convert this angiotensin 1 to angiotensin 2, which will also act directly to the blood vessel, stimulating the vasoconstriction because of the low stroke volume, low cardiac output, which is resulted by the low blood pressure. I hope that this is clear, and this is very important to understand how we will treat the dilated cardiomyopathy. So as we have the angiotensin 2 in the blood, that will directly affect on blood vessels. Why? To stimulate the vasoconstriction. Also, in the kidney, the angiotensin 2 acts on the adrenal gland to stimulate release the aldosterone. Why? Because the aldosterone will act the kidney to stimulate the reabsorption of the natrium. And we know that the natrium will affect, the natrium will also lead to the water retention. So this is very important to understand how then we are going to treat the patient. So let's start from the beginning. In the liver, we have the angiotensinogen, but it is not active. Then the renin will release from the kidney. Why? Because of the drop of the blood pressure and because of the drop of the fluid volume. Why? Because the stroke volume is very low, because of the cardiac output is very low. So we will have the kind of ischemia in the kidney. And this angiotensinogen, which is in the blood, is not active. So and then in the renin, and the renin release from the kidney will stimulate the angiotensinogen to angiotensin 1. And then the ACE, which is enzyme, which is angiotensin converting enzyme, will release from the lung to stimulate to angiotensin 1 to angiotensin 2. Okay? So this will act, ACE acts on angiotensin 1 to form the angiotensin 2, which will affect the blood vessel to stimulate the vasoconstriction. Why? Because we have the very low blood pressure. And then this angiotensin 2 will act to adrenal gland to stimulate the release of aldosterone. And aldosterone acts on the kidney to stimulate the reabsorption of the natrium, which will lead to the water retention. So this is how it works. I talk about it not once but several times because I want you to understand what happened in pathophysiology and why do the patient has these congestive heart failure symptoms. So as we know that we have the water retention, we have the tachycardia because of stimulation of the sympathetic nervous system, and then we have a water retention. But even when we have this water retention, this compensatory mechanism can no longer compensate the low ejection fraction. And we will have the clinical features of congestive heart failure. So will we have the shortness of breath, which name is dyspnea? We will have the fatigue. We will have the leg edema because of water retention. We will also have the palpitation because of the high stimulation of the sympathetic nervous system. Sometimes we can have the occasionally syncope. Why? Because the left ventricle, because the ejection fraction of the left ventricle is depressed, because the stroke volume is very low, because the cardiac output is very low. It means that the low stroke volume, low cardiac output means low oxygen in the blood. Also, we can have the systemic and pulmonary emboli, and also a typical chest pain. Sometimes it's not very typical to congestive heart failure, but sometimes we can have it. let's see how we make a diagnosis. So first of all, what is important is to make the good physical examination of the patient. So we have to auscultate the patient to hear if there is S3 or S4. Then we have to see if the patient has a tachycardia or not. Then we have to auscultate the lungs to hear if there is vent crackles or not, as a sign of congestion. And then we can switch. We can have a very good physical examination, history of the patient, to ask how is this disease started, what was the reason, how it started, what is just whether it was the sudden start, whether somehow a fever. So we can think that it could be because of inflammation or other symptoms, etc. And then we can switch to the diagnostic studies, which is, for example, chest X-ray, EKG, echo, when we can see, as I told you, the segmental or global wall motion abnormalities. We can also use for diagnosis the cardiac MRI. We can also use the cardiac catheterization to rule out the diagnosis of coronary artery disease, because it could be one of the etiological factors which led to dilated cardiomyopathy. So EKG, let's talk about the ECG. So in dilated cardiomyopathy, we don't have any typical features on ECG, which is especially typical for dilated cardiomyopathy. But we can see the abnormalities. Those are associated with the tachycardia, with ventricular hypertrophy, maybe. Typically left-sided changes are seen, but maybe also the biventricular hypertrophy. But I would say that it's not more than hypertrophy, but more it's the sign of dilatation. So looking at the ECG, of course, we can't say that this is the dilated cardiomyopathy, but we can definitely say there is something wrong, like STT changes were non-specific. What does it mean, non-specific? Non-typical to ischemia. So when it's not typical to ischemia, it's not specific, because you can never specify whether it's related to dilated cardiomyopathies or not, but you can see there is something wrong. Or sometimes you can see of the left ventricle conduction delay, and as for example left bundle branch block or right bundle branch block, or even interventricular conduction delay, which occurred due to cardiac dilatation. Chest X-ray will be helpful to see if there is a cardiomegaly or not. It means we can see if this heart is dilated or not, if the sizes of the heart is normal or not, and chest X-ray will be helpful to that. But also chest X-ray can be helpful to see if there is a signs of congestion in the lung, which you can auscultate. You can see the wet trickles. Also, you can see the signs of congestion in chest X-ray. Echo, we talked about it. Two-dimensional echocardiography can be helpful and can be crucial to establish the diagnosis of the dilated cardiomyopathy. Like, for example, in this patient, the apical four-chamber echocardiographic view with a severe dilated cardiomyopathy, you can see that all four cardiac chambers are markedly enlarged, and the left ventricle ejection fraction is about 22%, and left ventricle and diastolic diameter was about 74 millimeters. As I told you before, the cardiac MRI is very important diagnostic tool in the dilated cardiomyopathy, because in 2D dimensional echocardiography, you never know what is the damage of the myocardium. But in the cardiac MRI, which is the gold standard to measure the left ventricle ejection fraction, not only left ventricle, but both ventricles ejection fraction. But also, this is the 4-chamber view, for example. Here you can see the severe dilatation of the left ventricle as well as the left atria. Here is the 2-chamber view, when you can see the 3-dimensional approach to the heart examination. And this is the post-gadolinium contrast images. We use the gadolinium with a paramagnetic contrast media, which is used in cardiac MRI. Here you can see that there is a mid-wall fibrosis. Why this, I will explain you why these MRI images are important, because in these images you can see whether there is a fibrotic tissue, focal fibrotic tissue, which replaces the normal myocardium. So using the cardiac MRI, you can establish what kind of myocardial damage do we have. Whether we have the focal myocardium replacement or do we have the interstitial myocardial replacement. So like in this patient, we have only mid-wall fibrosis, and it's not seen here in this picture, but in this patient there is an interstitial fibrotic tissue which we cannot see here, but we have a special measurement tools for that. And it means that this patient has the genetic dilated cardiomyopathy, which causes laminopathy. Of course, to make the end diagnosis of cardiomyopathy, endomyocardial biopsy actually is needed, but as the cardiac MRI is not an invasive tool which can make a diagnosis and which has a very good correlation with the endomyocardial biopsy, the cardiac MRI sometimes is actually enough to make the diagnosis. But of course, as I told you, the endomyocardial biopsy is crucial. The only limitation of this method is that the method is invasive, so that's why it's not in the routine practice. This is the endomyocardial biopsy of the myocarditis patient with the findings of focal lymphocyte infiltrates and interstitial edema. And this is the biopsy of the end-stage dilated cardiomyopathy patient with the marked hypertrophy of myocytes, interstitial, also focal fibrotic tissue with no signs of interstitial inflammatory. What is the actual course and prognosis of this patient? So the most common complication of DCM is the progressive congestive heart failure. That will lead to the cause of death in the 50 to 75%. Sometimes dilated cardiomyopathy patients die suddenly, but that will be due to the fatal arrhythmia, and fatal arrhythmia is very, very common in patients with a focal fibrotic tissue. So there is studies which show that when the dilated cardiomyopathy, there is no any focal fibrotic tissue, also in the presence of interstitial fibrosis, they don't die. This patient will probably die from the congestive heart failure, from the pump failure, but not suddenly. But when in dilated cardiomyopathy there is a focal fibrotic tissue replacement, this patient can die suddenly. Sometimes it's systemic or pulmonary embolism can lead to the death. Prognosis varies considerably from fulminant cases that result in death within the weeks or maybe days also, or conversely some patients do remarkably well for a year, but most patients died within 5 years. Can the left ventricle actually function improve? Yes, it can improve, but it depends on etiology. So when the cardiomyopathy is primarily, there is no likelihood of the left ventricle improvement. In case if the cardiomyopathy is secondary due to some etiology, to ischemic heart disease, to infection, then the left ventricle is more likely to be repaired. This is about treatment. Let's talk about the treatment. So the treatment of left ventricle hypertrophy, again, when it's primarily, we treat only the signs and symptoms of congestive heart failure. When we have the etiology, we have to treat the etiology. But anyway, I want to make sure that you understood good the pathophysiology of the congestive heart failure, because we talked about the sympathetic nervous stimulation. We talk about the renin-angiotensin-aldosterone system, and I want to show you why it is important, because that will be the most effective points of the treatment, because we are using the ACE inhibitors. What is the ACE inhibitors? You remember, this is the angiotensin converting enzyme which is produced in the lung and which stimulates the angiotensin 1, which is not active, to switch to form to angiotensin 2, which angiotensin 2 will affect directly the blood vessel to stimulate the constriction. And we are going to stop, we are going to block this activation from angiotensin 1 to angiotensin 2 by using the ACE inhibitors. These ACE inhibitors are lisinopril, enalapril, captopril, so actually everything which ends with a pril. And then, so this is A. B is the beta blockers. Very important to use the beta blockers. So if you remember, we are talking about the compensatory mechanism which will lead to the stimulation of the sympathetic nerve system, which will lead to the tachycardia, and we are going to block this system as well by using the beta blockers like metoprolol, bisoprolol, or carvedilol. We are going also to use the EMRA antagonists, the aldosterone blockers. These are spironolactone or eplerenone. And you remember that aldosterone leads to the water retention, leads to natrium reabsorption in the kidney, which leads to the water retention. That's why we are using the EMRA blockers, not EMRA blockers. So three treatment strategies are very, very important to block the RAS system, to block the sympathetic nervous stimulation, to block the aldosterone blockers. So this is to block the aldosterone system. So this is the three pathways to block to improve the signs and symptoms of heart failure. Of course, by blocking all this, for example, by blocking the aldosterone system using the spironolactone, we are going to reduce the natrium reabsorption. Okay, but you are going to ask, before this, we still had the natrium reabsorption, and we have water retention, and that's why we have the wet crackles, we have the rales in the lung, we also have the leg edema. What we are going to do with that? So to release that signs, we are going to lose the loop diuretics. These are furosemide, etc. So ACE inhibitors, beta blockers, and aldosterone blockers are used to improve the signs of symptoms of congestive heart failure, but they are also affect to the mortality and morbidity of this patient. But the loop diuretics, they're not affecting too much the mortality and morbidity, but they are used to release the symptoms of fluid overload. So that's why these four groups of treatments of drugs are very, very important in the use of congestive heart failure. So let's switch to the other. These are digoxin and hydralazine. So digoxin has its own indications to use, but we are not going to go into the details. But please remember the ACE inhibitors, the beta blockers, the EMRA antagonist, the aldosterone blockers, spironolactone. Please do remember that. I didn't talk about the IRB blockers, this angiotensin receptor blockers. So if the patient has the contraindication or has the, for example, cough because of the ACE inhibitor, somehow of intolerance of the ACE inhibitor. So you can switch to the ARB blockers in case if there is something wrong or contraindication by using the ACE inhibitor. We also have the device treatment if in dilated cardiomyopathy. What is that? We talked that the patient sometimes, especially when the patient do have the patients do have the fibrotic tissue within the myocardium, sometimes this patient can die suddenly. And to prevent the sudden cardiac death, especially in patients with a reduced ejection fraction, according to the SCAD-HEF trial, it is indicated to the DCM patients to implant the ICD, the implantable defibrillator, the implantable cardioverter defibrillator. There is also the place of the use of CRTD. This is the resynchronization therapy of the heart. But this is another very, very long story that we are not going to talk about it today. But I hope that you understood very good the pathway of congestive heart failure, the etiology, which can be primary and secondary of dilated cardiomyopathy, and also the diagnostic strategy, but also the very good treatment strategy. And I didn't tell you that if the symptoms are still controlled, you may consider actually the heart transplantation. So let's switch to the hypertrophic cardiomyopathy. In the vast majority of all cases of hypertrophic cardiomyopathy results from specific defect in genes regulating the formation of cardiac muscle, and this defect is either sporadic or hereditary in the 50% of cases with autosomal dominant. In hypertrophic cardiomyopathy, we are going to talk about the two especially. One is obstructive or non-obstructive. In the non-obstructive case, we are going to have the concentric, midventricular, or apical hypertrophy. In the obstructive case, we are going to have the asymmetric obstruction, and we are going to have the asymmetric hypertrophy of the basal septal, which will lead to the obstruction of the left ventricle outflow tract, and that's why it's called like that. So the hallmark of the disease is the unexplained myocardial hypertrophy or hypertrophy out of proportion to the high hemodynamic load. It means that there is no reason, there is no etiology, there is no cause which can explain this very extensive myocardial hypertrophy. So frequently, when we talk about the hypertrophic cardiomyopathy, this is inherited with autosomal dominant transmission and the highly variable penetrance. We talked about the obstruction or non-obstructive cardiomyopathy, and I want to tell you that when we talked about the dilated cardiomyopathy, in reduced ejection fraction, so very impaired systolic function of the left ventricle, which led to heart failure. Also in hypertrophic cardiomyopathy, we are going to have heart failure as a symptom, but in this case, we are going to have the very reduced left ventricle diastolic compliance, which will lead to the heart failure with a preserved ejection fraction. So this is absolutely another pathway. So usually the asymmetrical hypertrophy with the septum, when the posterior wall thickness is more than 1 to 3, may occasionally be seen also in the concentric hypertrophy, but anyway. So apical mid-ventricle variants are unusual, but it can happen. Let's talk about the pathology which cause the hypertrophic cardiomyopathy. So when we talk about the asymmetrical septal basal hypertrophy, we are going to have the very, very hypertrophic of basal septum, like more than 16 millimeters, but it can be until the 30 millimeters. This extensive hypertrophy of the basal septum will lead to the obstruction of the left ventricle outflow tract. That will cause the turbulences in the left ventricle upstroke tract, and then the Venturi effect will work. How? When we have the turbulences in the left ventricle outflow tract, then the septal leaflet or the anterior leaflet in the systole will have the anterior motion. It means that in the systole, the mitral valve anterior lead is going to go anteriorly, is going to go further to the septum. And that will cause another obstruction of the left ventricle. So the thickening of the IVS of the interventricular septum is disproportionately greater than the left ventricle wall behind the posterior mitral leaflet. And that's why the left ventricle chamber will be small and will be also elongated. And this is the myofibrillar pattern in hypertrophic cardiomyopathy and the hypertensive patient. They are different, as you can see. Let's talk about the pathophysiology. In the systole, we are going to have the dynamic outflow tract gradient. What is it, gradient? The gradient, this is the difference between pressures in the left ventricle and the aorta. We all know to open the aortic valve, we are going to have the gradient. It means that we are going to have the differences in pressures between the left ventricle and the aorta. And this gradient will be very high because of obstruction. It may not be present at the rest, but it can be provoked. It may be provoked with the extra exercises, like squatting, for example, or in case if the patient is not able to make any exercises, it's going to be provoked. It can be provoked by inotropic drugs. In diastole, what will happen? So in diastole, we are going to have an impaired diastolic feeling. It means when in the diastole the muscles cannot be relaxed enough, then cannot be elongated enough, then to shorten good to make the systole. And as the left ventricle pressure will go high because of the stiffness myocardium, the left atrial pressure will go high as well, and that will lead to another load of the left atria, and then as a result the left atria is going to be enlarged, and as it's going to be enlarged, this is another base to the emboli, to formation of the emboli, the thrombotic emboli. And then as a result, this thrombotic emboli will go directly from the left atria to the left ventricle, and then from the left ventricle directly to the brain, and this is another one of the complications of the hypertrophic cardiomyopathy. And another pathophysiologist process which is also seen in hypertrophic cardiomyopathy patient is the myocardial ischemia. The muscle mass, as the muscle mass is very high, so the filling pressure is also very high, and then the oxygen demand is also very high. But the coronary reserve is not ready for that. And also, the abnormal intramural coronary arteries with systolic compression of the arteries will be another reason to myocardial ischemia. Symptoms. How do we make the diagnosis? As we have an ischemia, we are going to have an angina. As we have the gradient in the left ventricle outflow tract, we are going to have the syncope. Because when we have the asymmetric basal hypertrophy, which lead to the left ventricle outflow tract obstruction and gradient, we are going to have the turbulences, which will cause the Venturi effect. I'm repeating this. that the mitral valve's anterior leaflet, or as we call it, mitral valve septal leaflet, is going to move forward, is going to move anteriorly during the systole to make this gradient higher, and that will cause the syncope. The patient is going to have the palpitation, and the palpitation can be due to the atrial fibrillation. Why is atrial fibrillation one of the complications? We talked about it because the left ventricle is going to be enlarged because we have the load of the left atria, because of the left ventricle filling pressure is very high. And also another reason for palpitation is the ventricular tachycardia. And ventricular tachycardia is because of in the hypertrophied part of the ventricle is going to be myocardial mass is going to be replaced by fibrotic tissue. And this is another reason for the re-entry tachycardia, and that's why this patient can die suddenly because of the fatal arrhythmia like ventricular tachycardia. The patient can have also the symptoms of congestive heart failure, systemic embolism, we talked about it, and sudden death. We talked about it just right now. The diagnostic tool is very important to make the good examination. To have the EKG, because the patient can have the left ventricle hypertrophy pattern with a pre-excitation or abnormal Q waves with the giant T waves. Echocardiography, of course, is crucial to make the diagnosis to see what's going on with the left ventricle. Also, cardiac cath and cardiac MRI can be used. Let's talk about the increased gradient and the murmur. So it is clear, I think, that when we have the high gradient, when we have the left ventricle obstruction, I hope it's clear that we are going to have the systolic murmur. So the murmur in hypertrophic cardiomyopathy, in obstructive cardiomyopathy, is important to detect due to its clinical implication. So the murmur is high-pitched, is mid-systolic murmur, best heard at the left lower sternal border. The murmur doesn't radiate to carotid as it's seen in the aortic stenosis because it's not in the valve but in the left ventricle left ventricle outflow tract. The important auscultatory features of HOCM is distinguish it from aortic stenosis relate to dynamic auscultation. So the murmur of obstructive hypertrophic cardiomyopathy becomes quite loud with Valsalva maneuver. This maneuver effectively acts to decrease left ventricle filling pressure, which result in worsened left ventricle outflow tract obstruction in patients and making the murmur louder. I think that you have to read it again and again to understand. So this systolic murmur, which is best heard in the left lower sternal border, is mid-systolic murmur. And this murmur will be louder when this obstruction will be worse. Why it worse? It is dynamic. You can give an extra exercise, or you can give the Valsalva maneuver, and this maneuver effectively decrease the left ventricle filling pressure, which worsened the obstruction, and that's why this murmur will be louder. So I hope that is clear. In case if it's not clear, it's very important to read it again and again. ECG in hypertrophic cardiomyopathy results in increased precordial voltages with a non-specific ST segment and T-wave abnormalities. The asymmetrical septal hypertrophy produce deep, narrow Q waves in the lateral and inferior leads. So Be sure that, for example, this view of a young woman, a 45 years old woman with obstructive hypertrophic cardiomyopathy but pathological Q waves suggestive an old anterior myocardial infarction, but actually this is the patient with obstructive hypertrophic cardiomyopathy. This is the echo view of hypertrophic cardiomyopathy. You can see a very hypertrophied interventricular septum and posterior wall. And this is the parasternal short axis view, which can see the concentric hypertrophy of the left ventricle. And this is also the echocardiography. This is the left ventricle parasternal with the asymmetric hypertrophy of septum. This is the short axis view, and this is the long axis. This is the apical view, and this is the M mode. This is how it looks like in cardiac MRI. Very extensive hypertrophy of the basal septum. This is the four-chamber view, and this is the two-chamber view. So we talked about the clinical manifestation as it can be angina, but it can be also asymptomatic. You can find it only in echo. It can be also symptomatic with the heart failure, like shortness of breath or fatigue, presyncope and syncope. Prognosis depends on which kind of hypertrophic cardiomyopathy it is. So most patients do well. Some experience progression of the symptoms, and then you have to treat it. About sudden death, it's important to say that the young patient and children they die because it's familial form of the disease, and may result also from arrhythmia, even without significant left ventricle hypertrophy and obstruction. I mean, obstruction doesn't lead to death, to sudden death. Obstruction will lead to congestive heart failure. But even in the absence of obstruction, but with the presence of the left ventricle hypertrophy, when you have a replacement of mitral valve, the replacement of myocardial tissue by fibrotic tissue, you can have the sudden cardiac sudden death. To release the symptoms, the only way is to give enough beta blockers. It is very, very important to prolong the diastole, and beta blockers will provide the relief of angina symptoms, of dyspnea and syncope, will improve exercise capacity. So this is very, very important to give the beta blockers. About the device therapy, I have to tell you this is very important. Exist the calculators to measure the risk of sudden cardiac death within next 5 years, and when it's more than 6%, the ICD, the implantable cardioverter defibrillator, are actually recommended due to the prophylaxis of the sudden cardiac death. There is also the surgical treatment, so it could be done the septostomy, so you can just cut this extensive hypertrophy, but in case if there is still the fibrotic tissue, patient can die suddenly. So it's very important to make the diagnosis and to make sure that when you do the septostomy, you don't do the prophylaxis of the sudden death, but you can actually have the releasing of symptoms like angina or congestive heart failure. Sometimes the chemical septal ablation, the alcohol ablation, can be used, but actually this method is not really very good, and not much patients do benefit from that. The important thing here is to make the, like we said, the myocardial infarction by giving the alcohol in the septal branch of the artery, which is actually give the blood to this hypertrophied muscle. But this is actually not really very good. So to the risk factors for sudden cardiac death is the young age, the malignant family history, and the gen mutation prone to sudden cardiac death. So as I said, it's very important to calculate the risk of sudden cardiac death, and when it's more than 6%, just implant the implanted cardioverter defibrillator. This is the other causes that can lead to the hypertrophy and can mimic hypertrophic cardiomyopathy. And I have to say that the only method that can distinguish the two types of hypertrophy is actually this cardiac MRI and endomyocardial biopsy. Of course, we have to distinguish, we have to differentiate the hypertrophy from the athlete hearts, but this is another very long story. I'm not going to talk about it too much, but just be aware that when you have the hypertrophic cardiomyopathy, you have to do very good physical examination of the patient with auscultation. You can give time to ask about the history and especially family history of the patient, and then you have to make choose the good diagnostic tools like ECG, echo, and MRI, and sometimes cath. But restrictive cardiomyopathy, the pathology of restrictive cardiomyopathy is more or less the same as hypertrophic. So the etiology is usually infiltrative disease like amyloidosis, hemochromatosis, or glycogen storage disease. So this is actually all the storage diseases. Sometimes it could be idiopathic but it's not very common. So idiopathic when we don't know the reason. The thing is that we are going to have the congestive heart failure due to the reduced diastolic compliance, and as I told you, the etiology is the amyloid, the carcinoid, the Loeffler endocarditis, the sarcoidosis, the hemochromatosis. It could be glycogen storage disease, etc. Mucopolysaccharidosis. So these are all genetical diseases. The pathology of restrictive cardiomyopathy is more or less like in hypertrophic cardiomyopathy. I'm not going to talk about it too much because it's all about the etiology here. The clinical manifestation will come from the signs and symptoms of heart failure, left-sided but also right-sided, with a GVP like jugular venous pulse. You can see an echo Doppler, but what is very important, I want to make your attention to that, is to differentiate the restrictive cardiomyopathy from constrictive pericarditis. We have the echo signs which can differentiate two types, whether if it's a restrictive cardiomyopathy or constrictive pericarditis, but also you can use the additional tests like CT scan to see if there is a calcification of the pericardium, or MRI to see if there is a motion of septum, free breathing septal motion in the restrictive or cardiomyopathy or constrictive pericarditis, because the treatment of restrictive cardiomyopathies and constrictive pericarditis are different. In restrictive cardiomyopathies, there is no satisfactory medical treatment. We are going to use only the drugs that can release the signs and symptoms of heart failure, but not really to affect the etiology, excluding the ATTR amyloidosis, which we have the new treatment from 2018, but for the constrictive pericarditis, it is the surgical treatment. So as a take-home message, I'm going to tell you that cardiomyopathies have a different etiology, that the right diagnosis strategy will bring you to the right diagnosis, and the right diagnosis is always the right treatment. So I thank you very much for your attention, and in case if you have any questions, please you see my email, and you can text me to ask your question, and I thank you very much.